Can you guys hear me?
Yes.
Yes, we can.
Okay, can you all see my screen?
Yes.
All right, fantastic. So we'll get started. We're going to talk today about pediatric oncology emergencies during patient transport. I have no conflicts of interest, and this is an outline of today's talk. I'm going to start with childhood cancer diagnoses and potential times you can see those kids during transport and potential complications, and then we'll circle back and go over those complications and emergencies in more detail. And then at the end, I just put in one slide of how I evaluate the medical record and the labs if I need to have a quick overview of a patient, and I hope that'll be helpful. The objectives are to know the differences between common childhood malignancies, to recognize emergent situations arising from common childhood malignancy and their treatment, and to manage those situations if they arise during a transport. So starting out with the incidence of childhood cancer. It was increasing over time until the early 2000s and now has plateaued to about 172 new diagnoses per 1 million per year, which really, if you put it in other terms, is one patient for every 5,824 patients a pediatrician encountered. So it's really a rare diagnosis. It is a basket full of different diagnoses, the most common diagnoses being ALL with about 20%, followed closely by brain and central nervous system tumors. The lymphoma divided into Hodgkin's disease and non-Hodgkin's lymphoma is the third most common group, and the solid tumors make up the rest of them, and they are divided into all these different diagnoses. The incidence of childhood cancer varies with age. It's higher, the highest in the preschool age, then school age is relatively protected, and then it starts rising again in adolescence. The kind of diagnosis also varies with age, and you can see between the age of 1 and 4, leukemias are the vast majority and lymphomas are relatively rare. But then when you get into the adolescent age, lymphomas become more and more prevalent, as do brain tumors. Very early in life, neuroblastoma makes up a huge proportion. CNS tumors become more prevalent throughout, as I've already said. And then you see the different diagnoses. And as we are in adolescent, carcinomas, so more adult types cancers become more prevalent. Survival rates are very, very favorable compared to adult cancers. Overall, we now cure almost 84% of pediatric cancer patients. The highest cure rates we see in Hodgkin's lymphoma and in ALL, and what really lags behind are AML and our brain tumors, and everything else kind of falls in the middle. So overall, this is a huge success story, but it remains unfinished because there are still some kids who succumb to their diagnosis and are not cured. And then if we look at it the other way around, we got to these cure rates by intensifying therapy. But in 1970, we already cured, 20 to 30% of our patients. So these guys down here are now getting vastly overtreated. So the work we still have left to do is to get to 100% here. And we've pretty much maxed out on intensifying therapy. So it's unlikely that we'll get there by further intensifying therapy. While at the same time, we identify the good players that were cured with much less intensive therapy in the 1970s. So we stopped over treating them. And that's what current research efforts are really concentrating on curing the kids we're not curing and de-intensifying treatment for patients who can be cured with much less therapy. We're now going to go into the separate types of childhood leukemia. We'll start out with the separate types of childhood cancer, starting out with the leukemias. About 15% are AML and 80% are ALL. Of those, 80% are B lymphoblastic and 10% are T lymphoblastic. There are some very rare diagnoses of Burkitt leukemia arising from immature B cells, and then there are more rare subtypes. Of the AML, what you have to know is that in Down syndrome, these patients can also develop AML. They have a much higher risk, but they have an extremely good prognosis with relatively little therapy. And then really we see acute promyelocytic leukemia in childhood. So when may you encounter a child with leukemia? At diagnosis and during therapy, and you'll see slightly different complications. At diagnosis, they may present with tumor lysis syndrome, which goes along with renal dysfunction, electrolyte abnormality leading to cardiac arrhythmias. They may have a high white count and have symptoms of hyperleukocytosis, such as leukostasis, dyspnea, and confusion. They can have anemia, presenting with tachycardia, cardiac dysfunction, and orthostatic hypotension. If they have thrombocytopenia or coagulopathy, they may be at risk for bleeding. During therapy, you may transport a child with leukemia during a septic episode. If they need radiation therapy, some subtypes get cranial radiation, mostly only those who have CSF involvement at diagnosis, or they may be getting total body irradiation before they undergo bone marrow transplant. If you transport a kid during therapy, they may suffer from common side effects of therapy, which may include pancytopenia, so anemia, as I've described, or thrombocytopenia, or neutropenia, putting them at risk for sepsis. They may have mucositis, which goes along with a lot of pain and reduced PO intake, thus leading to dehydration, infection, as we've already said, and they may present with abdominal pain due to constipation, typhlitis, colitis, or pancreatitis. Moving on to the lymphoma, the incidence, as I've already told you, increases with age. Overall, it's equally split between NHL and Hodgkin's lymphoma, but Hodgkin's lymphoma becomes much more prevalent in the adolescent. The non-Hodgkin's lymphoma is a huge group of mixed diagnosis, which I won't go into due to time today, but it also changes over the course of a child growing up. Focusing on transport, again, at diagnosis, if you transport a newly diagnosed patient from one of our referring centers, patients may have tumor lysis syndrome. Those are most likely to be the young kids with Burkitt lymphoma or T lymphoblastic lymphoma. Patients with T lymphoblastic lymphoma, primary mediastinal B-cell lymphoma, or Hodgkin's lymphoma often present with a mediastinal mass that can lead to tracheal compression or superior vena cava syndrome. Some of our lymphoma, mainly anaplastic large cell lymphoma, can present with hyperinflammation on HLH-like picture. Those kids may be acutely hemodynamically unstable and might need fluid support and or pressor support. And then patients who have an abdominal lymphoma, which is most commonly seen in Burkitt lymphoma and anaplastic large cell lymphoma, may present with acute abdomen. In therapy, again, you may transport a patient during a febrile neutropenia or septic episode. If they need to go to radiation, we don't often use emergency mediastinal radiation. We've gotten away from that and now use more steroids. So you probably won't see that at Children's, but other institutions may still use it. If they go to transplant, they may get total body irradiation, and you may transport them during that. And then patients with Hodgkin's lymphoma sometimes get local RT. And for the most part, that's outpatient at that point. But if they are inpatient, you may transport them during that. Common side effects of therapy, you're going to see this repetition again and again because it goes for most of our chemotherapy regimens: pancytopenia, mucositis, infection, and abdominal pain. Moving on to the solid tumors, the most common extracranial solid tumor is neuroblastoma. It accounts for about 5% of childhood cancers. It is really a diagnosis of the very young child. About a third are diagnosed by age 1. 80% are diagnosed by age 4 and 90% by age 10. Presenting symptoms can be an asymptomatic mass, pancytopenia, raccoon's eyes, Horner's triad, and opsoclonus myoclonus, and 60% have metastatic disease at diagnosis. The second most common tumor is the Wilms tumor, which is also the most common kidney tumor in childhood. It accounts for a little less than 5% of our childhood malignancies. It's bilateral in 4 to 8% of cases, and about 2% are familial. The median age of diagnosis is 3.5 years, with a younger age in bilateral disease. So again, it's a disease of the preschooler, and overall survival rates exceed now actually 90%. So it has a very good prognosis. Soft tissue sarcomas are a heterogeneous group of malignant tumors that originate from primitive mesenchymal tissue. They account altogether for about 7% of childhood tumors, rhabdomyosarcoma being the most common one. And then patients who do not have rhabdomyosarcoma may have synovial sarcoma, fibrosarcoma, fibrohistiocytic tumors, or malignant peripheral nerve sheath tumors, especially if they have NF1. Malignant peripheral nerve sheath tumors is the most common diagnosis. Starting with rhabdomyosarcoma, their event-free survival has really improved, and their 5-year survival has also improved. They account for 3 to 4% of childhood cancer diagnosis. 50% of cases present within the first decade. And incidence depends on histological subtype, with embryonal rhabdomyosarcoma being more common in males and in younger kids, and alveolar being more common in the older kids. For all those solid tumors, I put them together for transport because usually you will be transporting at diagnosis a child with a solid mass, and you won't know what it exactly is. The only solid tumor that really presents with tumor lysis syndrome can be neuroblastoma. Kids with neuroblastoma are often ill-appearing at diagnosis. They may have they may be hemodynamically unstable. They may have a coagulopathy. If they have an abdominal primary, which is common for all of these, they may present with an acute abdomen, all of those tumors are prone to bleeding into the tumor. So you want to avoid any kind of trauma to the abdomen or aggressive abdominal examinations, because if they have an acute bleed into the tumor, they may drop the hemoglobin acutely and then become hemodynamically unstable. So if we have a known abdominal primary, we really try to prevent abdominal palpation. They can present with hydronephrosis if the kidneys are compressed or the ureters more commonly are compressed. These tumors can cause spinal cord compression, most commonly for neuroblastoma. And then neuroblastoma has a specific subtype, a more mature subtype, where you have an immune response to the neuroblastoma cells. And that immune response also attacks some of your normal nervous system and can lead to something called opsoclonus myoclonus. And opsoclonus myoclonus, you can see random eye and arm movement. It's not per se dangerous, but it's very disconcerting when you encounter it and observe it. The important thing to know is these are not seizures. Usually the child is responsive during it, and you don't need to do any acute intervention. So if you see somebody with rolling eyes all over the place and random eye and arm movements and an abdominal tumor, chances are this is opsoclonus myoclonus, and as long as they're hemodynamically stable and responsive, you do not have to acutely intervene. You can transport them. During therapy, again, you may see these patients during febrile neutropenia septic episodes. They may need emergency radiation if they have abdominal compartment syndrome. So then you'll transport them during that. Neuroblastoma, rhabdomyosarcoma, and Wilms tumor all sometimes get radiotherapy as part of local control. If they get abdominal radiation, they may have colitis and abdominal pain during transport. Wilms tumor may get whole abdominal radiation and rarely whole lung radiation. Again, may lead to colitis, abdominal pain, and also, if it's whole lung, pneumonitis. Common side effect of therapy are like with all the other chemotherapy regimens used for the other childhood cancers. Moving on to the bone tumors, there's two types, osteosarcoma and Ewing sarcoma. Osteosarcoma being more common. It usually presents in adolescent. It's most common in the femur, tibia, and humerus, but can also occur in the pelvis. And the important thing is an osteosarcoma can present with a pathological fracture. I've actually had patients who present to the emergency room being brought there by the parents in their own car, and the kid says, I heard the snap when I got out of the car. And then, yes, they do have that pathological fracture. The important thing about that is you want to protect the affected limb, which has the pain, which has the mass, because if they have a pathological fracture, that puts them at higher risk for an amputation. And I'll talk about that a little more in a moment. The other type is Ewing sarcoma. Again, presents most common in the bone, but can also present extraosseous. It about 30% present before the age of 10, but the majority again present in adolescent. It is rare to present after adolescent. So at diagnosis, you want to prevent a pathological fracture. If it happens, it contaminates the surrounding compartments and it complicates local control. Ideally, you would like to resect that tumor or that bone or part of that bone and prevent it and put a prosthesis in instead. However, if the surrounding compartments are contaminated, all of that needs to be resected as well, and then that risks a child needing an amputation. So protect the limb that it's affected during transplant. In therapy, most common type of transport is sepsis again. For Ewing sarcoma, patients do get radiation as part of their local control. For the most part, that'll be outpatient and won't require transport, but you could be seeing it. And then common side effects of therapy is the same as with all of our childhood tumors. The last group of tumors are the brain tumors. They account for about 20% of our malignancies. In the preschool age, they're most common in frontotemporal, so the brainstem and the cerebellum. In school age and adolescent, they become more common supratentorial. There are some inherited risk factors for developing brain tumors. Symptoms really relate to the location. Supratentorial, you may see vision changes such as optic pathway tumors, suprasellar tumors, hypothalamic tumors, and in occipital tumors. Seizures can be seen in frontal lobe, temporal lobe, and parietal tumors. In parietal lobe tumors, patients may have focal motor and sensory deficits. Frontal lobe tumors often lead to personality change. And then pituitary tumors can go along with endocrinopathies. Hypothalamic tumors often lead to obesity and temperature instability. For the infratentorial tumors, they're often associated with cranial neuropathy. Diplopia is seen if cranial nerve 3, 4, and 6 are involved. The facial nerve can lead to unilateral facial weakness. If cranial nerves 9, 10, and 12 are affected, patients may have drooling and swallowing difficulty. And if the third cranial nerve is involved, there may be ptosis and meiosis, but that could also happen from Horner syndrome, where the recurrent nerve is affected in the neck. Cerebellar symptoms include ataxia, and are most common seen in the preschool age. At diagnosis during transport, you may encounter increased intracranial pressures, seizures, personality changes, and lethargy. During therapy, all those may be encountered again, and then all the other problems we see during therapy due to complications from chemotherapy. And then patients' brain tumors often require radiation for cure. So you may also transport them during radiotherapy. So we're going to move on to the oncological emergencies and dive into a little more detail with tumor lysis syndrome, hyperleukocytosis, and fever and neutropenia, SVC syndrome and tracheal compression, and the neurological complications of ICP, spinal cord compression, and encephalopathy. Tumor lysis syndrome happens when the cell lyses either spontaneously or in response to therapy, and the slide animation is not working very well. Tumor lysis syndrome is defined as the metabolic abnormalities resulting from tumor cell death. That can happen either spontaneously. So you may be transporting a newly diagnosed patient who already has tumor lysis syndrome, or it can be treatment related. The classic triad is a high uric acid, high phosphate, and high potassium with secondary hypocalcemia. It occurs mostly in tumors with rapid growth rate, wide dissemination, and high sensitivity to chemotherapy. And those are leukemias, lymphoma, and less commonly stage 4 neuroblastoma. Complications from tumor lysis syndrome include metabolic derangement, cytokine release, renal dysfunction and failure, cardiac arrhythmias, and if you have a high potassium or low calcium seizures, and eventually multi-organ failure. We have to manage it prior to initiation of therapy, and the goal is really preserving the renal function. So during, if a patient is already diagnosed with tumor lysis before you're going to transport him in from a community hospital, the important thing is to continue the hydration during therapy. Hopefully they will have started uric acid reduction and correction of the electrolytes before they're going to put them in your ambulance. And you want to make sure that during treatment, you're going to keep them on a cardiac monitor so you can pick up any cardiac arrhythmias. Hyperkalemia can be treated with alkalization, albuterol, calcium gluconate, Lasix, insulin, and K-exolate, but you should not have to do that during transplant. That should have been completed or at least stabilized before you transport a child. Hyperphosphatemia is hard to treat, and especially in the end, you can only, it slowly decreases with aluminum hydroxide or with dialysis, so you may have to transport a child with a high phosphate. And do not forget your cardiac monitoring. Hyperleukocytosis is encountered in childhood leukemias. Leukemia is actually the Greek word for white blood emia. And this is actually the pheresis product of one, or the exchange product of one of my patients who presented with a white count of 3 million. And since her total red cell count was in the 1 million range, she was severely anemic. Her blood actually looked white, which is very rarely seen, a white count that high. It's defined as a white blood cell count of greater than 100,000 and occurs in about 10 to 20% of pediatric leukemias. It is more frequent in ALL than in AML. However, it is more dangerous in AML than in ALL. And the reason for that is that myeloblasts are much more rigid and larger than lymphoblasts. Complications from hyperleukocytosis come from the capillary sludge that leads to organ failure and increases the risk of stroke. And then obviously also tumor lysis syndrome. Risk factors: hyperleukocytosis is much more common in the infant and much more common in myelomonocytic and monocytic leukemia. So it leads to obstruction of circulation, most commonly in the brain, lungs, because of the formation of white thrombi that then compete for O2, damage the endothelial wall, leads to secretion of cytokines and to the activation of endothelial cell. I already told you it's much more dangerous in AML because myeloblasts are much larger than lymphoblasts. Most patients with hyperleukocytosis have no symptoms. However, if they start having white thrombi or capillary sludge in the CNS, they may present with mental status changing, headache, papilledema, or seizures. If they have sludging in their lungs, they may present with dyspnea, hypoxemia, or right ventricular failure. And then they can also develop priapism, renal failure, and dactylitis. So if you have to transport a patient with hyperleukocytosis so they can initiate treatment at Children's, the important thing to know is you want to have an adequate platelet count before you put that child in your ambulance, because there's a risk of secondary hemorrhagic stroke if they have an ischemic stroke due to white thrombi. So you want to make sure the sending institution raises the platelet count to greater 20,000. You want to make sure that this kid is not in florid DIC. Because hyperleukocytosis can lead to endothelial damage that then leads to the release of tissue factor that initiates DIC. And blast, especially monoblast and promyelocytes, can also produce tissue factor leading to DIC. So if there is DIC, you want to ask for FFP for correction before you take the kid. However, you're going to tolerate a lower hemoglobin than you usually do. Giving these kids packed red cells will just increase viscosity, and that may make all these other problems worse. So we do not want to raise the hemoglobin above 6. So try to be a little flexible about your hemoglobin. And then at all costs, avoid diuretics. These kids may be dyspneic, and you may think they're fluid overloaded, but that just may be from pulmonary leukostasis. So you're going to make matters worse with diuretics. Moving on to fever and neutropenia and sepsis, what we tell our parents is, you call us and come in at a temperature of 38.3 times 1, or if that 38, and this is Celsius, is maintained for more than 30 minutes. But your temperature varies. You know, should you take it orally, ear, armpit? We prefer orally, but we say never rectally, because if you take a rectal temperature in a neutropenic kid, you can, any kind of rectal stimulation can lead to transient gram-negative bacteremia. And if a child is neutropenic, they cannot control that. So then you may actually introduce a bacterial infection. Neutropenia is defined as an absolute neutrophil count less than 1,000, but severe neutropenia is what we care about. So that's less than 500. Most of the labs now report an absolute neutrophil count, but if you don't, you multiply the total white cell count by the percent of neutrophils. Fever may be the only manifestation of a serious infection in an immunocompromised. However, and this is important to know, patients on corticosteroids may not even have a fever. They may just have unspecific signs of irritability, lethargy, tachycardia, and decreased urine output. So in all of our neutropenic patients, whether they have the classic symptom of fever or they have non-specific signs, our suspicion of bacterial infection and or sepsis is always very, very high. And if in doubt, we are going to treat them as if. At the outside hospital, they should have a targeted history and physical examination. The central line site should be inspected and make sure that the tunnel is not irritated or tender. We asked for inspection of the oral and perianal areas to make sure there's no mucositis, which puts patients at higher risk for anaerobe infections. And then the outlying institution should do a CBC with a differential, blood cultures from each lumen, electrolytes, type and cross, evaluate unstable patients for coagulopathy, and do a quick search for a source. Not all neutropenic oncology patients are the same. Depending on the chemotherapy regimens, there are differences in the degree and the duration of neutropenia. And then there's also other concomitant factors that alterate the host defense, such as corticosteroids, hypogammaglobulinemia in patients who have gotten B-cell directed therapy, such as rituximab, blinatumomab, or CAR T therapy, and patients who are on chronic immunosuppressions, such as transplant patients with medications such as tacrolimus, cyclosporin, or sirolimus. Then also, it is important to look for other breaches of host defense, such as mucositis, diarrhea, changes to colonization, or the normal gut flora due to prior antibiotics or C. diff, and what type of venous access they have. They're at lowest risk for infection if they have none. A Metaport has a lower risk than a Broviac. A PIC has a lower risk than a Broviac as well. These patients require prompt initiation of broad spectrum antibiotics, and the standard of care is to administer broad spectrum antibiotic within an hour of presentation. Obviously, cultures need to be sent first. We always, taking into consideration prior infections, chemotherapy received, most common organism, and type of venous access, we always start gram-negative coverage first. Sometimes we have to start double gram-negative coverage. Gram-positive coverage is for select patients with mucositis that have catheter-related problems, such as not flushing or drawing back, or tenderness over tunnel lines, or patients with previous line infections. So usually gram-positive coverage can be started at the receiving institutions, so once they get to children's, but they do need to have the gram coverage before they get into an ambulance. The gram-negative coverage of choice at children's is cefepime. Ceftazidime is also acceptable. In a kid who has abdominal symptoms, it might be Zosyn. Kids who are allergic to cefepime may need to get meropenem. Gram-positive coverage and all the other anaerobe coverage, fungal coverage, can be started once they're safely arrived at children's, but they need to have gram-negative coverage on board before they get transported. In the unstable patient, so presumed septic patients, you also want to make sure they are stabilized before they transported with fluid resuscitation. And if they need pressor support, the PICU needs to be involved, obviously, in transporting them. If they have symptomatic DIC, they should get FFP before transplant. And then they need to be followed closely once they get here. Moving on to SVC syndrome and tracheal compression. So those, for all intensive purposes, are the lymphomas who present with anterior mediastinal masses. And here you see the trachea basically be completely flattened. So we see SVC syndrome and tracheal compression in non-Hodgkin's and Hodgkin's lymphoma, rarely in neuroblastoma, germ cell tumors, and sarcomas, which are all in the posterior mediastinum. It is much more dangerous if you see it in the anterior mediastinum, because then the trachea is being compressed as a patient lies flat, than if it's in the posterior mediastinum with the trachea is anterior to it. Signs and symptoms may include cough, dyspnea, dysphagia, wheezing and stridor, hoarseness, facial edema, chest pain, plethora, so redness or cyanosis of the face and upper extremity, distension of the cervical and thoracic veins, injection of the conjunctiva, pleural and pericardial effusions. SVC syndrome can lead to CO2 retention and central venous stasis, and that can lead to anxiety, confusion, lethargy, and distorted vision. The most important thing is to not agitate the patient and do not place the patient in a supine position. More commonly, they are in the anterior mediastinum, so let your patient sit up and do not sedate them. They need all the ancillary muscles to keep that airway open. And obviously, acutely, you diagnose it with a chest X-ray. So you can radiate these kids and see improvement as early as 12 hours. That would require transport at Children's, so we don't really do that. We usually start with prednisone acutely to keep the airway open. You want to try to avoid prednisone prior to transporting a new diagnosis without having had a biopsy, because that may complicate making the diagnosis. However, there are situations where we have to empirically start prednisone. Just 2 weeks ago, we received an international patient who came from Uganda via South Africa and then was put on a plane halfway through. It was a State Department referral who was supposed to go to Seattle, where the family was from. Seattle decided it was too dangerous to have the child fly all the way to Seattle, so they diverted him to us. But thankfully, Seattle had decided to give him empiric steroids prior to sending him on his journey. And he got here in a stable state. However, we had a very limited window to make the diagnosis and send him basically straight from arrival to the OR, and we were able to make the diagnosis of Hodgkin's lymphoma. So try to avoid steroids. When in a bind, you have to, but then we have a limited amount of time to make a tissue diagnosis. So make sure the receiving institution knows when, how much steroids were given. Moving on to seizures and encephalopathy, risk factors are brain tumors and brain metastases. There's a higher risk in supratentorial tumors than in infratentorial, and especially in temporal lobe tumors. Electrolyte imbalances, hypoglycemia, trauma, chemotherapy, and cranial RT are all also associated with seizures. Ifosfamide and methotrexate can lead to an encephalopathy, and these kids may present obtunded or very confused. For acute seizures, protect the patient from injury, protect the airway, check the glucose, establish access, and then treat it with benzodiazepines, mostly acutely. Most of our patients will have a central line, so lorazepam is the drug of choice. If you don't have access, midazolam can be given intranasally or buccally, and you would use the IV solution. Increased intracranial pressures most commonly happens with infratentorial tumors that compress the outflow tract. Posterior fossa tumors include meduloblastoma arising from the vermis of the cerebellum, ependymoma arising from the lining of the ventricles, and intrinsic brainstem gliomas. Supratentorial, we may see primitive neuroectodermal tumors, germ cell tumors, and gliomas. The symptoms really vary by age. Across the spectrum, you can see somnolence, but young children may have more unspecific symptoms such as macrocephaly, developmental delay, poor feeding, failure to thrive, irritability, vomiting, or even chronic GI symptoms that can really delay diagnoses. In older kids, you see the more classic symptoms of morning headaches, vomiting, and those symptoms improving during the course of the day. Diagnostically, you can see papillary edema, neurological defects related to tumor location in the posterior fossa, as I've already mentioned, ataxia and cranial nerve deficits, supratentorial seizures and focal deficits, and suprasellar diabetes insipidus, so increased thirst and urination, and endocrinopathies. Usually the diagnosis is made acutely by non-contrast CT, and you want to evaluate whether there's hydrocephalus, midline shift, and what the risk of herniation is. And then an MRI is needed for more definitive tumor evaluation. During transport, keep the head elevated at 10 to 30 degrees. Acutely, you cannot overdose on Decadron, so you don't necessarily need to know the weight. When in doubt, give 10 milligrams. It does not treat the tumor, but it often treats the surrounding edema, and just relieving that gives enough space for the kid to symptomatically improve. It's also a very good antiemetic, so it helps with that as well. And then you really need the involvement of our neurosurgical colleagues, and that requires the kid getting here safely. And then lastly, let's talk about spinal cord compression. All patients with new back pain and a known malignancy have all patients with new back pain and a known malignancy have spinal cord compression until proven otherwise. Just assume that. Can cause local or radicular pain, progressive weakness, paresis, paraplegia, or quadriplegia, sensory abnormalities, and if it's a complete compression, urinary and fecal incontinence, which is a medical emergency because you need to intervene before this becomes permanent. You want to pay attention to the neurological exam at the sending institution, especially the sensory level, the extremity strengths, whether patients have a positive Babinski, because that would actually point to a supratentorial insult and not a spinal insult, and whether they have reflexes. Typically, they should lose their reflexes if it's a spinal cord lesion. If there's hyperreflexic, then you assume that this is going to be a supratentorial lesion. Sphincter tone, if they're incontinent, and then for diagnosis, they require an MRI, but that may require them to be transported first. Tumors that can cause spinal cord compression are Ewing sarcoma, neuroblastoma, osteosarcoma, rhabdomyosarcoma, Hodgkin's lymphoma, germ cell tumors, and then the primary CNS tumors of gliomas, ependymomas, and primitive neuroectodermal tumors. Acutely, you load them with Decadron. Again, you cannot overdose. And then continue maintenance dosing. They do require either neurosurgical intervention with laminectomy or emergency radiation and or chemotherapy. And lastly, just a quick slide about nausea, emesis, and abdominal pain, since it's so common in our patient population, causes anything our patients can have: chemotherapy, radiation, infection, hypoglycemia, pancreatitis, which we can see in response to chemotherapy, most commonly in ALL therapy, and colitis. The acute management during transplant is mostly antiemetic, which we do. Our first line is ondansetron or another Kytril or other, I'm spacing HT5 inhibitors. Lorazepam can also be used, so benzodiazepines, and then Benadryl is another good option acutely during transplant. Now, if I want to have an overview of a patient very quickly to kind of get a mindset, what do I need to know acutely to make sure this patient is stable? I look at the progress note and concentrate on the diagnosis, current status of the cancer, where is it located, what is the extent of disease, what are secondary diagnoses that could get me into trouble, and I read the plan of care. Then I go and I look at the most recent vital signs and the urine output. I review current laboratory values, especially concentrating on any electrolyte abnormalities, pancytopenias, coagulopathies, and on any blood gases if they've been done. If there's disseminated disease, so the extent of disease, I might review the imaging. I look at the current medication and the allergies, and I use all that to kind of synthesize a picture of the patient to evaluate what can go wrong. And once I've decided on my own what can go wrong, does he have electrolyte abnormalities that I need to have addressed before I take over care? Is there coagulopathy that I need to have addressed before transplant, or is transport, or is all of it within acceptable parameters for me to take this kit? I will still look at the trends of all of these so I can make a reasonable contingency plan as I've outlaid for you. And I hope that helps a little bit, giving you guys an overview. This was really kind of a tour de force because it's such a broad topic, and I went through it pretty fast because I wanted to leave time for questions. So that brings me to the end of what I have to tell you, and I want to thank you for your attention, but I'll be more than happy to answer any questions. Are there any questions? Or have I lost all of you guys?
A lot of information to take in, but just not as much questions, but it's just a lot of information it's just helpful to get a review of all of everything.
Thank you. Any questions? Oh, I saw, okay. What is mucositis and typhlitis? Mucositis is basically interruption of the epithelial barrier throughout the GI tract. There are certain chemotherapy drugs that can lead to it, methotrexate and anthracycline, such as daunorubicin and doxorubicin being the most common one. And in the oral cavity, you may see little white spots that can become confluent, can lead to bleeding. In the lower GI tract, the most common sign of mucositis is diarrhea. In the upper tract, if it occurs in the mouth, it puts the patient at higher risk for gram-positive infections. And then we may add vancomycin if a patient has a fever. In the lower tract, it's mostly the anaerobes. So then we add something like Flagyl. Typhlitis is a specific infection of the cecum that we see in neutropenic patients. And again, it's often associated with anaerobes. So patients with typhlitis require coverage with cefepime and Flagyl. They typically have pain and tenderness in the right lower quadrant. And on imaging, their cecum looks thickened. Other questions?